Well, good afternoon and welcome to everybody. It's a pleasure to have you here on this beautiful day, and we certainly appreciate you taking a few moments out of your schedules to spend time with our medical experts today. My name is Jeff Rivest, and I have the pleasure of serving as the President and Chief Executive Officer of the University of Maryland Medical Center. I want to welcome you today and thank you again for your attendance and your interest in our Health Matters program. This is the second program of what we hope will be a regular series of opportunities for you to hear directly from expert physician researchers of the University of Maryland School of Medicine and the University of Maryland Medical Center about their pioneering work in various fields of medicine. Their discoveries will continue to impact medical practice and improve outcomes for our patients and for patients throughout the country and around the world. And you're going to have access to 5 of these experts directly this afternoon. We're truly honored to be able to bring this group of leaders together to talk with one another and to talk with you. I'd like to acknowledge just a few special guests we have in the audience today that are great volunteer leaders in various parts of the University of Maryland and have done a lot to help us bring this program together today. We have representatives here from our Marlene and Stewart Greenebaum Cancer Center Board of Advisors, chaired by Stuart Weitzman. We also have University of Maryland Children's Hospital Board of Visitors here today, chaired by Jen Stearman. The R. Adams Cowley Shock Trauma Center Board of Visitors is represented by several of our board members here today, and a special thank you to our chair, Senator Frank Kelly. And then the larger University of Maryland Medical System Board that oversees the 12 hospital system throughout the state of Maryland is chaired by Steve Birch. We welcome Steve today and thank you for your leadership. The University of Maryland Medical Center is part of the University of Maryland Medical System, a 12-hospital network providing acute and critical care, emergency care, rehabilitation services, and primary care across the state of Maryland. In addition to the University of Maryland Medical Center, we are pleased to have representatives from a number of UMMS affiliate hospitals here today, including the University of Maryland Baltimore Washington Medical Center, the University of Maryland Charles Regional Medical Center, University of Maryland Shore Health System, University of Maryland Upper Chesapeake Health System, University of Maryland St. Joseph's Medical Center, and the University of Maryland Rehabilitation and Orthopaedics Institute. And hopefully in that list, I've hopefully touched maybe one part of a geography that you have come from in the state of Maryland or that you're familiar with. Again, we have quite an imprint across the entire state. The University of Maryland Medical Center is the academic medical center where the majority of Maryland's physicians, nurses, and other healthcare providers receive their professional training. It is also a place where the most complex conditions and the most serious injuries are treated by our multidisciplinary team of expert physicians. Partnership and collaboration with our School of Medicine are at the center of our work and our philosophy every day. I'm pleased to welcome today Dr. Reece and a number of our School of Medicine faculty who are essential partners with the Medical Center in everything that we do caring for patients every day. They assist in training the next generation of physicians and all healthcare providers. They conduct research that will open broad new possibilities for better treatment in the future. I'm going to just take a moment now, and as I thank Dr. Reece for his presence and his support here today, offer you a brief introduction of Dr. Reece, and this is a brief introduction. This is quite an accomplished gentleman, and I do want to hit a couple highlights of his career. Dr. Reece is going to function as our facilitator today, and I think you'll enjoy his involvement with us here today. Dr. E. Albert Reece is the University Vice President for Medical Affairs and the John Z. and Akiko K. Bowers Distinguished Professor and Dean of the University of Maryland School of Medicine. He is also a professor in the departments of obstetrics and gynecology, medicine, and biochemistry and molecular biology. He's a member of the prestigious Institute of Medicine of the National Academy of Sciences and recently started the 3-year term on its governing council. Originally from Jamaica, West Indies, Dr. Reece has a bachelor's degree from the Long Island University, a medical degree from the New York University School of Medicine, a PhD in biochemistry from the University of West Indies, and an MBA from the Fox School of Business and Management at Temple University. As you can see, Dr. Reece spent a part of his life enjoying being a student. Dr. Reece completed his internship and residency in obstetrics and gynecology at the Columbia University Medical Center and a postdoctoral fellowship in maternal fetal medicine at Yale University School of Medicine. He remained on the full-time faculty at Yale for almost 10 years. In November 1990, and Dr. Reece, I have to tell you, this is the part I enjoy. In November 1990, at the young age of 39, do you remember that? Okay. He was recruited as one of the youngest department chairs in the country by Temple University to serve as the Roth Professor and Chairman of the Department of Obstetrics, Gynecology, and Reproductive Sciences. Between 2001 and 2006, he served as the Vice Chancellor of the University of Arkansas for Medical Sciences and Dean of their College of Medicine. And in 2006, we were most fortunate to attract Dr. Reece to the University of Maryland School of Medicine to become Dean. In addition to his vast administrative responsibilities, in his spare time, he is actively involved in research and education. His research focuses on diabetes in pregnancy, birth defects, and prenatal diagnosis, and he directs a multi-million-dollar research laboratory funded by the National Institutes of Health. Dr. Reece is a sought-after lecturer and speaker with many publications, many books published, and over 500 articles currently in print. With that, it is my pleasure to turn over the program today into the able hands of Dr. E. Albert Reece. Welcome, Dr. Reece.
Thank you very much, Mr. Reece. Thanks very much. Jeff promised that it would have been a short introduction, but it was quite a long introduction, Jeff. Well, anyway, thank you very much for coming. It's just wonderful to see so many of you here this evening for our Health Matters program. As Mr. Reece said, this is our second tour in this wonderful venue, and we're just delighted that so many of you are here this afternoon. We hope that much of the information that we share with you you'll find very useful as you conduct your lives and as you arrange your schedules and activities accordingly. Before I go further, just let me make one other brief comment. I too, like Mr. Reece, want to make a word of thanks. And the word of thanks would like to go to Marlene and Michael Greenebaum. Those of us who came yesterday afternoon from Baltimore, many of us, were hosted in their lovely home yesterday afternoon, and we are so grateful that you opened your home and hosted us in such a generous manner. So we very much appreciate that. I also want to make one other comment I think that's relevant. And most recently, Michael Greenebaum, on behalf of his family, has made a very generous contribution, and specifically in honor of his father. And I think it's worthy of note. Michael, on behalf of his family, has made a contribution to the School of Medicine of $1 million. That has launched a professorship in stroke neurology to recognize his father's illness. And I think that is a wonderful, wonderful signature event that has occurred, and we very, very much appreciate it. So, Michael, on behalf of the entire Greenebaum family. So let me tell the group a little bit about, as Mr. Reece said, what I would refer to as University of Maryland Medicine, which is indeed a combination of the University of Maryland Medical System and the University of Maryland School of Medicine. Our two organizations often use the phrase, the power of partnership, to guide our efforts and to seek opportunities to align the medical school and the medical system, and particularly the medical school with a flagship hospital, the University of Maryland Medical Center. Our collective goal is to improve the health care of the citizens of Maryland and the nation. Let me share with you just a brief history of medicine in America. Medicine in the United States began in 1765 at the University of Pennsylvania. That was the first medical school. The second medical school was a little north, and that was Columbia University College of Physicians and Surgeons. The third medical school went a little further north, and that was Harvard Medical School. The fourth medical school went further north, and that was Dartmouth Medical School. The fifth medical school and the first public came back south, and that was University of Maryland School of Medicine. So we have a very rich history and a very good company that we keep. Over the past 200 years, the School of Medicine has educated and trained thousands of physicians, have conducted groundbreaking biomedical research, and our research is one that is focused on transforming medicine and patient care on a daily basis. It's not about theoretical research, but research that has an impact on human health. It's also very much involved in providing exceptional clinical care. Many of our programs are destination programs where individuals will travel throughout the state, the region, and in some cases from various parts of the nation to receive their care. Today, the combination of our clinical care and our research accounts for more than 90% of that which we do on a daily basis. The main emphasis of the school is to conduct biomedical research that transforms clinical care, that informs that which we do and transforms it as well. Many of our research programs are focused on things that create significant morbidity, mortality, or disability, things that matter. Health matters. That's our focus. Just to give an example of a few of our large, robust research programs that are having this transforming impact. Cancer, large program. Vaccine development, so large it's worldwide. It's in many countries, Chile, Mali, Malawi, Bangladesh, all over the world. Focus on how we can provide vaccine coverage, vaccine for various diseases. H1N1 vaccine in the United States, the University of Maryland led the charge in developing the vaccines for the United States. Third, mental illnesses. That's a major effort that we have been involved in. The Schizophrenia Research Center is the largest schizophrenia research program in the nation. Fourth, transplantation of all sorts, whether it's solid organ transplantation or blood-related transplantation, stem cells, major efforts underway. And of course, cardiovascular medicine and surgery. These are the number 1, 2, 3 cause of death in the United States. According to the Association of American Medical Colleges, the School of Medicine ranks number 7 out of 76 public medical schools nationwide. Out of the 140 private and public medical schools nationwide, we rank number 20. There's a very strong partnership that we enjoy between the school and the medical center and the medical system. What I think is most interesting and most important that I'd like you to take away is the fact that our physicians and scientists are very much involved in discoveries on a daily basis that have an impact, that are promulgated throughout the state of Maryland, that have impact throughout our system hospitals, and also get propagated throughout the nation. I'd like to close this overview by giving you just 4 examples of how we organize our lives in a way that we truly use discovery to transform and impact medical care. Let's start with number 1, breast cancer. That is obviously a very relatively, unfortunately, common disease that we have to deal with. One of our distinguished scientists, Dr. Angela Brody, was the scientist that discovered a class of drugs called aromatase inhibitors. And simply put, it's a series of drugs that actually block the transformation, the biochemical transformation to estrogen, which drives breast cancer. By blocking it, she's been able to have a significant impact on treatment. It is now used as the number 1, the standard of care for treatment of postmenopausal breast cancer nationwide and in some cases worldwide. Dr. Brody is not done yet. She's now on the verge of another breakthrough. She has worked with her colleague, Dr. Vincent Najjar, in developing a compound for prostate cancer in the tablet form, and is now in clinical trials, and the preliminary results are actually very positive. So that is another breakthrough that is underway, starting from the laboratory and is now in patient clinical trials ongoing. The second example I'd like to give you, and that is work done by Dr. Stephen Bartlett, who is a chair of surgery, and his colleague, Dr. Ralph Barth. They have been interested in looking at the wounded in Afghanistan, Iraq, injuries around big cities where people have actually lost limbs or have facial injuries, basically composite tissue, whether it be bone or muscle or vessels. How can we transplant them safely, consistently, and have the graft take? And so for 10 years, they've conducted laboratory research and experimental research. That last year resulted in the most extensive face transplant in the world. That was research that began in the laboratory at the University of Maryland that resulted in this groundbreaking transplant case. The third example I want to share with you is work of one of our physicists, Dr. Cedric Yu. Dr. Cedric Yu, working collaboratively with the chairman of radiation oncology, Dr. Bill Regine, has developed a number of things. In fact, he's an incredible inventor. But most recently, as we speak right now, he's developed a new innovation called Gamma Pod for breast cancer. We're using radiation in a very directed manner, can actually kill the tumor in situ without surgical removal. And that is now in the very, very late stages of development and is going to be making an impact very soon. The last example I want to share with you is work done by one of our neurosurgeons or practicing neurosurgeons. What happens, as you know, when there's traumatic brain injury, as happened in Arizona when that Congress lady, I forgot her name now, Congressman Giffords, was shot in the head, brain swells. And when brain swells, you have to sort of remove a part of the brain to allow it to swell. Dr. Mark Samard, one of our neurosurgeons, has actually identified through laboratory work a particular receptor that can be activated to reduce brain swelling even during conditions of injury or strokes. And it's been using, but interestingly enough, a simple drug, a drug that's on the market for diabetes care. But first he had to do the laboratory research to understand the biology, and now that work is in clinical trials and is going to have a direct impact. So these are just 4 examples of how we use discovery-based medicine to transform care that we provide and the impact of patients on their lives. Now, we have a very distinguished group of panelists, and this is just a small sampling of truly wonderful faculty that we have at the School of Medicine. We have almost 3,000 faculty. About 1,500 are full-time faculty members paid on a salaried basis. Another 400 are part-time, and another 1,000 are adjunct faculty. So this is just a small sampling of a very distinguished group. And I'd like to introduce you to them very briefly. Their full biographical sketches are in the documents. So let me just give you a very brief introduction, and let me share with you the format. I'll briefly introduce them. Then I will ask each of them to give you a little vignette, a little overview, and it'll be a short overview. And I have a rod to pull them back if it goes more. A very short overview of some of the things they're doing, some of the impact, and then we'll sit back together and get into a little dialogue of discussion. I'll ask questions, and then I'll have you ask some questions as well. So it'll be very interactive, but first let me introduce them. First, Dr. Lisa Schulman, to my immediate left. Dr. Schulman is the Eugenia Brin Professor of Parkinson's Disease and the Director of the University of Maryland Parkinson's Disease and Movement Disorders Center. Dr. Schulman studies the impact of chronic neurologic diseases and evaluates early interventions to prevent disability and improve the quality of life. To her left is Dr. Andrew Pollak. Dr. Pollak is the James Lawrence Kernan Chair and the Professor of Orthopaedics, as well as Chief of Orthopaedics at both the Medical Center and the medical system. Dr. Pollak is focused on developing programs that deliver safe, effective, and reliable musculoskeletal care to patients in Maryland and around the nation. The third person who will speak to you is Dr. Susan Kesmodel. Dr. Kesmodel is Assistant Professor of Surgery and Director of Breast Surgery. Dr. Kesmodel is interested in the management of benign and malignant breast diseases, with specific interest in the management of high-risk patients. And finally, Dr. Kevin Cullen. Dr. Cullen is the Marlene and Stewart Greenebaum Distinguished Professor in Oncology, as well as the director of the University of Maryland Marlene and Stewart Greenebaum Cancer Center. Under Dr. Cullen's leadership, the Greenebaum Cancer Center has achieved elite National Cancer Institute designation and is widely recognized by the U.S. News & World Report, as well as other ranking instruments, as a top-tier cancer center nationwide. I should mention in closing that all 4 of our panelists are well-published, are well-regarded, are highly sought after, and have had prestigious award. So I'm very delighted to have them as my colleagues on the platform, and will ask them to make brief comments in the manner in which I've just introduced them, and then we'll have a little dialogue together. Dr. Schulman.
Thank you. It's a pleasure to be here and a pleasure to tell you about the University of Maryland Parkinson's Disease and Movement Disorder Center. Parkinson's disease is one of those areas that is very rewarding to work in. A chronic neurologic disease that is really treatable, and we can do a fabulous job of maintaining people in terms of their daily function and reasonable quality of life for many years now. So what do we do that sets us apart when we're caring for our patients? Well, one of my jobs as director of our program is to develop a truly comprehensive and patient-centered program. And a comprehensive program means that we should be providing a full range of treatment options. Not just what we do have, fortunately, are a number of very effective symptomatic medications, but we also now have surgical options in Parkinson's disease. You may have heard of deep brain stimulation surgery, where electrodes are actually placed into the brain in the area that's affected in Parkinson's disease, and this actually relieves symptoms when the medicines are no longer able to be effective. We have a very active DBS program in collaboration with our neurosurgeons. We also have a very active research program I'll tell you a little bit more about, and a good research program should have not only pharmaceutically funded research to look at the newest possible medication pharmacologic treatments, but also we have a range of private foundation-funded, government-funded, philanthropic-funded research in our own areas of interest. The area of interest I'll be telling you a little bit more about later is that one of my main interests is exercise and its impact in Parkinson's disease. And it's really wonderful that this area, which for many years I was very interested and enthusiastic about, but really couldn't draw funding, is now drawing a lot of attention and a lot more research. I'll be telling you more about it. So all of us at times do experience illness, and why should you seek a subspecialist, somebody with special expertise in your disorder? Well, you may think that it is easy or just straightforward to diagnose a disorder like Parkinson's disease. But actually, misdiagnosis is extremely common. There is no blood test or neuroimaging scan that gives you a precise diagnosis of Parkinson's disease. One of the nice things about being a Parkinson's expert is that it actually requires an excellent history from the patient and family, as well as a full neurologic exam to be sure of the diagnosis. The fact is that we do see people who go undiagnosed for years. I think of one woman who, for 9 years, went undiagnosed and literally could hardly walk into the office. She had been told for years this was some sort of nervous disorder. Parkinson's had never been considered, and it was truly Parkinson's disease, and she did fabulously with therapy. The opposite occurs too, however, where some people have been told they have Parkinson's and they're on medications for years, and it turns out that in fact it is not Parkinson's disease. So it is very important to have a diagnosis confirmed by a specialist in movement disorders. So we can also provide very up-to-date information and as I say, an access to a full range of therapeutic options. And the image that's on the slide is actually a book that I wrote with my colleagues for patients and families about Parkinson's disease. So many of us think that every disease is entirely different, but when it comes to chronic illness, you'd be surprised that actually there's a lot more similarity than differences, because in every case, you have to learn about how to live with a new disease, how to manage the medications, the treatments, the doctor's visits, and still go on with a productive and hopefully rewarding and satisfying life. So I find that it's more similar than different. Everybody has to learn what we call self-management skills, how to actually manage the disease. And a key factor that we're studying as part of our research program is an area that's called self-efficacy. Self-efficacy is the confidence one has in managing your condition. And interestingly, it turns out to be more important, your level of confidence to manage your condition, than your actual skill in managing your condition. Because without confidence, people may become quite isolated, stay home, not be socially engaged as they used to, and so forth. So I like to think that our overall goal is to minimize our patients' disability and maximize their quality of life. And this can only be done by understanding individualized problems, not using any algorithm or guidelines. It's always a matter of what is this person's individual problem. At the end of the day, we need to find a balance between the reality of living with a difficult disease, difficult symptoms, and the hopefulness that comes from not only the treatments we have, but the treatments we are very active in developing. And this patient is actually one of our patients at our program, and he had gone on hikes all his life, big hikes, out west, where they were like treks, and he would stay overnight for many nights out in the west, in the mountains. And he came to me and he said, I know I'm getting more advanced. He said, but I'd like to do this one more time. He said, and I'm thinking it through. He said, I'm going to have my buddy carry a second jar of my pills in case I fall in the creek when I'm going across it. And he said, and I told the leader of the trip, he said, that I have Parkinson's, and the leader's going to call you, and you can have an honest conversation with him. Ultimately, he went on the trip, and here's a photo of him out in the mountains. And when he came back, he said, it was one of the best trips of my life. He said, what really made it possible were the llamas. He said, the llamas, were carrying the packs. But really what made it possible was the fantastic resilience that he showed. Thank you.
Dr. Andrew Pollak.
Thank you. I want to talk about joint replacement, and joint replacement in Maryland specifically. I'm relatively new to this role of Chief of Orthopaedics for the medical system. I've been in the role officially for about 5 months now, but I'm not new to Maryland. I've been at the University of Maryland Medical Center for just under 20 years, and for the past 10 years, I've been Chief of Orthopaedics at Shock Trauma. So I'm sort of bringing with me to this role of Chief of Orthopaedics to the system, the shock trauma background, and hopefully a little bit of the shock trauma philosophy, and I'll explain a little bit more about that. Why joint replacement? Well, I think it's important, first of all, I think many people in this room are probably familiar with the concept of joint replacement, either very familiar or at least familiar with somebody else who's had it. There are about 1 million hip and knee replacements a year done in the United States right now. That number is expected to grow to 4 million a year by 2030. That's a dramatic increase based on the aging of the population. It's based on the increase in obesity in the population, based on the change in activities. But it suggests that we've got a really big problem. And right now, the U.S. government's spending $50 billion a year on joint replacement. Much of that is driven by the cost of complications associated with joint replacement. So anything that we can do to develop innovative ways to bring down the complication rate, to make joint replacement safer, to make it work better so that it lasts, and so that it happens every time you do it, to make it safer, more effective, and more reliable, is critically important. And we believe will attract substantial research funding in order to develop systems to better do that. You say, is joint replacement new to the University of Maryland? Well, absolutely, it's not new to the University of Maryland. In fact, if you look at the state of Maryland, joint replacement in the state of Maryland, we own the largest market share of with regard to hips and knees. We are the #1 provider of hip and knee replacement in the state of Maryland, but that's split across a bunch of hospitals. And there are lots of differences in the way that joint replacement care is delivered. There are lots of things that can be learned from one hospital and applied to another, and that's what we hope to do over the course of the next year or two. We want to develop the safest, most effective, most reliable programs so that patients can feel very comfortable that they can predict what kind of result they're going to get when they show up. In order to do that, we have to measure and report on our quality, safety, and efficacy. We have to really bear things out and show people where we're having complications and where we're not, and learn from places where complications are occurring, and learn from places where they're not and apply them to the other places. We're going to do that in a very, very deliberate way. We want to increase quality. And quality is a combination of things. You hear a lot about quality. You hear a lot about integrated healthcare delivery systems to improve the delivery of quality. Well, what is that quality that we're trying to improve? Well, it's patient satisfaction. We want to make sure that the systems are done so that when you come into a hospital for a joint replacement, you know what you're going to get, you get it, and you get it in a friendly fashion and in a safe fashion every time. We want to make sure that your outcome's the best and that you have the fewest complications possible. That means that you know that when you come in to get your hip replaced, you're not going to be back in the hospital 2 weeks later with a complication from that hip replacement. Most of those are preventable. We know it. We're already doing it. We need to measure it, demonstrate it, and demonstrate it to everybody else so that they know that this is the best place to come for hip and knee replacement. We're implementing a series of standardized outcomes instruments across all of the hospitals so that we'll be able to measure across our 12 hospitals and compare to hospitals around the country how well our patients are doing after joint replacement. If we can measure it, we can change it, we can affect it, and we can make it better. If we don't measure it, we're not going to be able to do that as well or as effectively. But there are certain interesting things that we can do in that regard. We can take the series of protocols that exist and standardize them to one protocol across 12 hospitals with some variability that's necessary based on each individual hospitals, and then develop educational programs for the nursing staff, for the therapists, and for the patients. Put those online, require the nursing staff and the therapists and the patients to view them before the procedures occur so that everybody comes in on the exact same page as to what's going to happen, when it's going to happen, and how it's going to happen. That does an awful lot to decrease variability, to decrease the risk of complications, and to improve patient satisfaction by taking a lot of the fear away in terms of what they might expect. I want to standardize all of our postoperative protocols and standardize the tools even at the level beforehand. And that level beforehand includes the shared decision-making tools, which many of you may have heard about. Shared decision-making tools are instruments and materials and videos that patients can view before they even arrive for the first time at their surgeon's office to allow them to understand what joint replacement is, what they can expect from it, what they shouldn't expect from it, what the potential risks and benefits are, and how to ask the right questions when they get to the doctor's office the first time, and then provide tools like that for them to take home so that they're educated consumers at each step along the way. We're establishing what's called the American Joint Replacement Registry at each of the system hospitals over the course of the next several months. That's a level 3 registry where we record and report on the types of implants patients are getting, the types of complications that they incur over a period of time, and their specific outcomes using validated outcomes tools that will allow us to compare apples to apples from center to center and across the United States. We'll be able to benchmark ourselves to hospitals around the United States and around the state, really in a way that no other hospital system of this size is able to do anywhere in the country right now. This is all linked to the electronic medical record in a way that ensures that all the information is downloaded immediately and doesn't require excess work. And we're going to expand this to include every hospital in the system where we're doing joint replacement. We have some necessary next steps that we're engaging in over the course of the next month. Just this morning, we were working on dates to put teams together where we reconcile the clinical pathways that exist at each of the hospitals right now and develop the best practice clinical pathway that can be applied across the system, develop these educational tools, implement the program, and then develop an ongoing certification program for our nurses, our therapists, our physicians, our residents, so that everybody's on the same page and everybody's certified on a regular basis with regard to what the safest, most effective, most reliable ways are to deliver this care. We're going to begin the development of the shared decision-making tools shortly. Some of them are already in place. We just need to modify them to be most appropriate to a larger population, develop the pathways further, and develop the shared decision-making tools in a way that manages the patient's expectations with regard to what they can expect. There's a lot out there about minimally invasive surgery, about painless surgery, about painless joint replacement surgery, and that simply doesn't exist. What we need to do is make sure that people have reasonable and appropriate expectations, and that dramatically improves patient satisfaction. There are many studies that show that. But there's a big academic advantage in all of this too. When you create this model across 12 hospitals and collect this amount of data with regard to outcomes in joint replacement, you can learn an awful lot about what the best, safest, most effective, most reliable practices are. And that's information that the federal government is very interested in us studying and in helping us study through the Patient-Centered Outcomes Research Initiative, or PCORI. There are tremendous opportunities for us to use this clinical base as an opportunity to dramatically expand our research programs, particularly in the clinical realm, but additionally in the basic science realm. Thank you.
Dr. Susan Kesmodel.
So what I'm going to do is, can you all hear me? Yes? What I'm going to do is give you a little bit of background on breast cancer. And I think, as we've heard, breast cancer is one of the most common cancers. And probably everybody here in the audience... Can you turn that off? Yeah, I'll stand up here. Probably everyone here in the audience knows someone who's been diagnosed with breast cancer, and I think there are probably multiple breast cancer survivors in the audience. And I'm going to give you some statistics, show you what we've done over the last kind of 40 to 50 years, and then specifically focus on what we're doing at the university. So as I already mentioned, breast cancer is the most common malignancy in women besides skin cancer. And in 2013, it was estimated that there were about 230,000 cases of invasive breast cancer and a little over 60,000 cases of non-invasive breast cancer. And those are about the same numbers that we expect for 2014. I listed some risk factors here. I think most people know that obviously gender and age are the primary risk factors for breast cancer. And more than 75% of breast cancers are going to be diagnosed in women who are over the age of 50. Well, we've come a long way in the last 50 years, and I just listed 5 things here that have been major advances in the treatment of breast cancer, and I'm going to go through each of these briefly. First of all, screening mammograms. I know there's been a lot of press about screening mammograms recently and over the last several years. But I do think that screening mammograms are important. They do allow us to detect breast cancer at a very early stage, and then that's when it's most treatable and when a woman has all of her options available. I can't forget that we do diagnose breast cancer in men as well, but it's much rarer, only about 2,000 cases a year. And screening mammograms have been shown to decrease mortality from breast cancer, so I don't think that we can completely eliminate them from the armamentarium yet. One of the major advances in breast cancer is that we're able to do a lot less radical surgery now than we had to do in the past, and we have similar outcomes for patients. So we're doing a lot less surgery, and with additional medical treatment and radiation, we can provide excellent cosmesis, excellent survival, and we have to do a lot less surgery, so patients have fewer complications, and I think it's better for everyone. We've developed a lot of new medical therapies. There's been a lot of focus on research for breast cancer, and so we've been able to develop new medical therapies, and I think most people are familiar with this agent, trastuzumab, also known as Herceptin, which targets a specific receptor on breast cancer cells, and this has dramatically improved outcomes for women with breast cancer who overexpress this receptor. And on the other side, the aromatase inhibitors As Dean Reece already mentioned, Dr. Angela Brody, a researcher at the University of Maryland, was instrumental in the development of aromatase inhibitors, which block the production of estrogen peripherally, and this medical treatment has now become the standard approach for estrogen blockade in postmenopausal women. So really taking something from the laboratory to the clinic and having a significant impact on outcomes for women with breast cancer. We have gained a significant amount of knowledge about breast cancer in the last decade, exponential knowledge. And as we've always known, breast cancer is not one disease. It's a whole host of diseases which have different molecular characteristics. And by understanding the different characteristics of tumor, we are able to better individualize treatment for patients. So in the past, we might have said, you have a 2-centimeter tumor, you have positive lymph nodes, you're going to get chemotherapy. But now we know that there are a lot of women who don't respond well to chemotherapy, and we might be able to give them estrogen blockade instead, and they will do equally as well. So our knowledge about the molecular characteristics of breast cancer has really allowed us to individualize treatment for patients. And then finally, we do know more about the genetics of breast cancer as well. We know that patients who have specific genetic mutations, these are just 2 that we know of right now, but they're at a significantly increased risk for developing breast as well as ovarian cancer. And by having this information, we can change screening for these patients or try and intervene early to prevent the development of breast cancer. At the University of Maryland, I think one of the strengths of our program is that we have a very strong multidisciplinary team of physicians who focus primarily on breast cancer. So we have medical oncologists, radiation oncologists, and surgeons whose primary focus is on breast cancer. And we also have a whole host of other healthcare providers that help us manage patients, including research nurses, genetics counselors, and our radiologists. And by having this team, we're able to have multiple clinical trials. We have many cooperative trials which are testing various drug combinations. We also work with drug companies. And then here I've listed some of the ongoing research from just investigators within the university. So Dr. Brody continues to look at endocrine therapy for patients. She's looked at mechanisms of resistance because we know that patients eventually develop resistance to endocrine therapy. Now we're looking at how endocrine therapy might work differently in obese patients. We're looking at mechanisms of weight gain during chemotherapy. As Dean Reece already mentioned, the development of new radiation delivery devices, which may eventually lead to less surgery for breast cancer, use of MRI to assess for breast cancer recurrence, and also methods to decrease treatment effects. Just as Dr. Schulman mentioned that exercise might be beneficial in patients with Parkinson's, we also think that exercise may be beneficial in patients receiving chemotherapy and endocrine therapy to decrease side effects and decrease the inflammation that is produced. So these are some of the things we're specifically focusing on at the university. Thank you.
And our last formal speaker is Dr. Kevin Cullen.
Thank you. Thank you again for coming and for the opportunity to talk to you a little bit about. Dr. Reece and our previous speaker have given you a little bit of the background of some of what I'll talk about. But just to set the stage, cancer is still a very, very major public health issue in the United States. There are about more than 1.5 million new cases of cancer every year in the United States, and about 600,000 deaths. So aside from heart disease, cancer is the largest cause of death in adults in the United States. In Maryland, we see about 30,000 new cases of cancer per year with about 10,000 deaths. So it's an enormous problem. 1/3 of women will develop cancer at some point in their lifetime, nearly 1/2 of men. Cancer is much more common over the age of 55, and it has an enormous cost, both in terms of morbidity and for all of you who've had either a personal experience or the experience of a loved one who's suffered from cancer. We know the dramatic social and societal impact that cancer has, but the cost in dollars is gigantic as well. What's really important, what I think people don't realize, is that more than half of cancers are preventable with what we do today. And I talked to a group of high school science teachers, and I said, you can teach your high school students how they can cut their risk of developing cancer by more than half. Two very simple things: never smoke, keep your body mass index below 23. That means just keep your weight in a normal range. If you do those two things, you've reduced your lifetime risk of cancer by more than half. I'm very proud. I've just finished my 10th year at the Greenebaum Cancer Center, and I'm enormously proud of what we've done, both for citizens in Maryland, but as part of the national and international war on cancer. As Dean Reece mentioned, we became what's called an NCI, National Cancer Institute designated cancer center in 2008. That means we're among the top cancer research organizations in the country, and I'll give you a couple examples of some of the work that's been done there. There are about 900 cancer treatment facilities in the United States where people who are diagnosed with cancer go for treatment, and consistently we've been ranked in the top 50 for the last 5 years or more. So we're really viewed now as one of the top cancer programs in the country. The NCI Cancer Institute designation focuses on research, but it has a very practical meaning for cancer patients as well. Studies have shown that if you have your cancer treated at an NCI-designated cancer center, your survival is 20 to 30% higher than if you go to a center that's not so advanced. So it really is important for patients in many, many ways because we have top faculty, we're doing clinical research, we're doing important basic research. We have a number of cancer programs. We have more than 250 cancer researchers who are part of the Greenebaum Cancer Center. Basic scientists like Dr. Brody, who Dr. Kesmodel talked about a little bit ago, and top-notch surgeons, radiation oncologists, medical oncologists. Dr. Santha is here with us, are just superb folks to work with and really committed to cutting-edge patient care. We're committed to clinical research. This is how cancer care gets better. Last year we had more than 250 clinical trials open at some point in the Cancer Center. And very importantly, we feel it's critical to serve our community. Over a third of our patients are African American, and historically, less than 2% of African Americans who develop cancer participate in clinical trials. And we know for a whole host of reasons, morbidity and mortality from cancer is much higher in that population than it is in many other populations that we serve. At the Greenebaum Cancer Center, about a third of our patients, or a third of our African American patients, compared to 2% nationally, participate in clinical research. And we're very proud of that, and we know that it's a very, very important part of our contribution to the understanding of better treatments for cancer. So, one of the important aspects of clinical care, but also of research, is multidisciplinary care. Cancer medicine is a team sport. If you're treated for cancer these days, certainly at a place like the Greenebaum Cancer Center, you're likely to see a team of specialists who will come together and come up with a coordinated care plan for you and follow through on that care plan throughout every phase of care. We have a number of cancer survivors here in the audience, and they can tell you the importance of that multidisciplinary approach. In past days, seeing a single physician to navigate through your care, or seeing several different physicians at different locations and having to try and pull that care together yourself is a very daunting prospect. But we really do offer comprehensive services to all of our patients. We have some very, very highly developed research programs, and ranging from viral oncology. Another important thing that we've learned in recent years is many cancers are caused by viruses, and a number of those are preventable. So hepatitis virus, papillomavirus, these are causes of significant numbers of cancers, and we have vaccines against many of these viruses, and so part of what we're doing is enhancing our understanding of how to use those vaccinations to prevent those cancers from happening. Tumor immunology and immunotherapy. We are able to rally the immune system to defeat many cancers. Many of you read about some important work that's gone on at the University of Pennsylvania in certain leukemias. That's been done in collaboration with Dr. Aaron Rappaport here at the University of Maryland. And we've seen some really remarkable results in how we can engineer the body's immune response to attack leukemia and other cancers very specifically. We have a rich history of developing new drugs and refining the use of drugs, and in understanding the molecular biology of cancer. Michael Greenebaum correctly points out that if you say the word enzyme or molecular biology, he starts immediately to fall asleep. I'll keep that discussion very minimal. But to highlight a little bit more what Dr. Kesmodel and Dr. Reece said, the shining example, and we keep coming back to it, but it's such a striking example, it bears further mention. Dr. Angela Brody developed a number of years ago now the drugs aromatase inhibitors. And when she says she contributed to, she didn't contribute, she developed it, invented it in her laboratory at the University of Maryland, made the first clinical batch. She couldn't get anybody to sponsor her research. She couldn't get any pharmaceutical company to participate with her. She said, I think this drug is going to work. I'll make it in my own laboratory. She had to set up special conditions in her lab, but there's a wonderful picture of her with a bag of white powder. It looks like she's selling cocaine. But this was the first batch of an aromatase inhibitor, and it really has revolutionized the treatment of breast cancer around the world. For a postmenopausal woman who's had breast cancer, it reduces the chance of her breast cancer recurring by more than 40%. For a woman who's at high risk for developing breast cancer, it can reduce the chance of her getting breast cancer in the first place by 60%. For a woman who has a large, what we call locally advanced breast cancer, who would need a mastectomy, total removal of the breast, it reduces the need for mastectomy by more than 50%. There's nobody in my mind who has contributed as much to the field of breast cancer in the last 50 years as Angela Brody at the University of Maryland. But for the gentleman in the audience, as was mentioned, she took a similar approach and said, I think we can do the same thing for prostate cancer. And with a collaborator at the University of Maryland, a wonderful chemist named Vincent Najjar, she invented a drug which is now called Galaterone. This drug was very promising in laboratory models and went into the clinic about a year and a half ago. Now, for those of you who have any knowledge of cancer research, when a new drug goes into the clinic, basically what we're looking for at first is it safe? Can we give it to patients safely? We hardly ever expect that we're going to see a meaningful response to the drug. We know if you work up very, very slowly, maybe in a second or a third phase trial, you'll start to really see some responses, and if you've got a good drug, you may see that. In Angela's case, with the new drug Galaterone, in the first group of men that it was given to in a safety trial, and again, this is a pill with almost no side effects, and these were men who had the worst of the worst prostate cancer. They had had previous treatment, their treatment wasn't working, their prostate cancer was getting worse. In the first clinical trial, more than half of the men who received this drug responded to it and had their cancers improve. Their blood tests got better and their CAT scans got better. That's unheard of. That's in oncology, that's virtually unheard of, that a new drug, the first time it's given to humans, to people with cancer, would have that kind of efficacy. So the Food and Drug Administration has identified a new, what's called a fast-track approval process for really, really promising drugs, and this is one of the first drugs that was ever given that FDA designation. So the second phase clinical trials are now ongoing here at Maryland and at Hopkins and a couple of other places, and we're very optimistic that this drug will be approved very, very quickly. A couple of years ago, Dr. Brody received what's called the Kettering Prize, the General Motors Cancer Research Foundation Kettering Prize, which is given for the most important advance in the treatment of cancer in the world. Very, very prestigious award. We think that with the work on Galaterone, that Dr. Brody is a very, very strong contender for a Nobel Prize, and our hope is that before she retires, she'll receive that honor. So just a couple of examples. I know you've heard about it before, but I wanted to elaborate a little bit more on the kind of work that we're very, very proud of, that we think is really making important contributions both in Maryland and in a much broader venue as well. And I think I've covered those things, so with that, I'll turn it back to Dr. Reece.
Okay, so this is time to have some fun. Now, some of my questions are going to be provocative, so don't take them too seriously. It's really an attempt to have our panelists provide more information or provide a different kind of information. So let me start with Dr. Schulman here. Dr. Schulman, you gave the example of one of your patients who had a delayed diagnosis because presumably the symptoms or signs were not recognized early enough. What difference does that make? I mean, she has it or she doesn't. If she has it early, and you diagnose it early, could you make a difference with treatment or not?
Well, it's actually a very good question because we really differentiate two different things in terms of how we can impact the course of a disease. And one is whether we can impact the actual mechanism of the disease within the brain. You know, obviously, nerve cells, neurons are being injured in Parkinson's disease. Nerve cells that have a very strong impact on our motor function, our movements. And we would like to be able to fundamentally be able to turn back the clock, so to speak, and prevent that injury to the brain. But there's another way that we can make a strong impact, and that is in terms of one's function. You know, so on the one hand, we'd like to slow what's going on in the brain. On the other hand, we would like to delay disability. So where we are in the field of Parkinson's disease is that, unfortunately, we don't have the magic bullet to turn back the clock in terms of the damage in the brain. But we have very effective therapies to delay and prevent disability over time. And that is by no means trivial, because without those treatments, people were literally wheelchair bound after a very short number of years with Parkinson's disease. Today, people continue to have a very robust function for many years when they are well treated. And it requires expertise for excellent treatment. People that you know, like Michael J. Fox, who unfortunately had a very young onset, 32 years of age, he's actually had his Parkinson's disease for 22 years now. And yet continues, yes, he has symptoms. However, he continues to be very participatory in life and getting enjoyment out of life.
Let me pose a follow-up question. There's a lot of reports about the role of exercise. What do we know about exercise? Does it work? And if so, why does it work? And what does it do?
Well, we did a very interesting study of exercise at the University of Maryland, and in fact, it was funded by the Michael J. Fox Foundation. And in the study, we compared, and it was a very high-quality study, and it's important in research that you do a study where it's randomized. That means people are randomly assigned to different study arms, and that the rater is blinded, doesn't know which type of intervention the person receives, and so on and so forth. So this was a very rigorous study. And the patients were randomly assigned, all Parkinson's patients, to 3 different types of exercise. Either they randomly were assigned to get what we called low-intensity treadmill. They were on a treadmill, but they were walking at their own comfortable speed. But they were going 3 times a week for 3 months, and over time, were increasing their time walking at this nice, comfortable speed. The second group was on a treadmill doing strenuous exercise. So they were going faster over time, greater incline, and so forth, more of an aerobic stimulus. The third group was only working with resistance machines, muscle strengthening machines, lower body strengthening. And our main interest was, could we improve their walking? Because mobility walking is the main source of disability in Parkinson's disease. So the punchline is that the study results were fascinating. Very often, you could spend millions of dollars on a study and have negative results, not have learned much. But in this case, we learned a lot. Number one, all 3 groups improved their gait velocity. They were able to become more mobile, better mobility in all 3 groups. But the group that did the best of all was counter to our hypothesis. sitting there thinking, as we did, that the higher intensity treadmill would be the most effective. But in fact, the lower intensity treadmill group did the best of all. It's very interesting. We can't be entirely sure why. Our group sort of speculates that maybe walking at your comfortable normal speed is the best simulation of actual walking. The second group, the resistance group, also did second best. The higher intensity was the third best of the group. Interestingly, they got better for different reasons. The treadmill group improved their cardiovascular fitness. Only the resistance group improved their strength. So the take-home message is maybe doing both is really the way to go.
Well, Dr. Schulman, I'm going to hold my third question for later on. I'm going to put that one in escrow. I'm going to move to Dr. Pollak. Dr. Pollak, you know, we're living longer these days. Americans and America and the world is living longer. So is it just inevitable that we're all going to need to have our joints redone or replaced based on wear and tear? Is that normal? Is there such a condition as bone health that would have prevented our bones from wearing out, or they're going to wear it anyway?
No, there are clearly some people who live a long, healthy life without needing any joint replacement. And I think the key to that is picking the right parents.
That's a good point. I'll think of that.
Genetics plays a big role. How you live your life plays a big role. So wear and tear on the knees. We know that trauma to knees more so than hips, plays a big role in your risk of arthritis. But there are some things that we're starting to pick up. People earlier in life that suggest that they're at increased risk for wearing out the cartilage in their knees, wearing out the cartilage in their hips, and eventually needing joint replacement. Some of it's malalignment. Malalignment is when you see people who are either bow-legged or knock-kneed. Well, if you can't catch a greased pig in an alley, chances are you're going to wear out the inside of your knees a lot faster than you wear out the outside of your knees. There are operations that can be done to improve things. Generally, we wait for symptoms to occur. But it's important to know that when you have symptoms and deformity at a young age, it's important to see an orthopedic surgeon and important to really get a professional opinion as to whether something can be done to prolong the life of the cartilage in the knee joint. There are new things that are being done in cartilage transplantation, both use of your own cartilages, it's in stem cell work. Some of that work is being done in Kurt Siven's lab at the University of Maryland. And use of cartilage from other people. And even there's some direct transplant techniques that use cartilage from the same knee that's not under, that's actually not being used as directly, and move it to a place where it's necessary. So lots of things can be done.
Well, let me follow that up a little bit. Clearly, it's a lot better to prevent something than to have to treat it. Is there any recommendation that you'd give to this audience regarding how we could prevent or bone deterioration? For example, we've all heard of nuances of diet and exercise. Is there anything to that, or is that just tabloid information?
No, there's clearly something to it. People who live healthier lives live longer lives, and people who stay in good physical condition to a degree are less likely to need joint replacement. But it was sort of like what Dr. Schulman was saying. It's that high intensity stuff that may not be as good for you long term as the lower intensity stuff. So exercise that leads to weight bearing on the joints, that increases weight bearing on the joints. For example, running on an outside track can actually lead to more rapid deterioration of joints. Yet the cardiovascular component of it can be very good. So things that generate good cardiovascular exercise without the same stress in the joints tend to be better. Things like swimming as opposed to running, or use of an elliptical, or use of a bike instead of running. Running tends to be one of the worst things.
So if we use low impact activities. And would you recommend a non-hard surface place to run?
Yeah, but if you've got to choose between running and staying sedentary, running's better. Sedentary is the worst thing that you can do in terms of joint health, in terms of all sorts of aspects of your health. Sedentary and fat are worse than running.
Thank you. I'm going to move on to Dr. Kesmodel. Let's talk about breast cancer and some of the primary risk factors that you would identify for breast cancer. And if you would just follow that up by responding to, should someone proactively seek medical attention even in the absence of symptoms or signs if they happen to be in the quote-unquote high-risk group?
So I think that all women should discuss their risk factors with their primary care physician, and also look at their family risk factors, their personal risk factors, and should determine if they're at a higher risk for developing breast cancer than anyone else in the general population. We know that we have a more obese population now, and postmenopausal obesity increases risk of breast cancer. We know that family history significantly increases breast cancer. So I think that conversation of family history and your own risk factors with your primary care physician is important, and then you can decide what kind of screening methods you should utilize for each patient. There are different recommendations out there for how we should screen patients. Some of them recommend starting screening at 40, and others recommend 50. Again, I think it's a conversation that I think it's something that needs to be individualized for each patient. If you're at a higher risk, you might consider using other screening modalities. We have, besides mammograms, we have MRIs, and we have a newer type of screening called tomography. And we don't really know right now how to apply these to the general population, but in the future, I think we'll have more information about how to utilize these other screening modalities. I think in an asymptomatic patient with no risk factors, again, it's a decision about the risks and benefits of screening, and also modifying those modifiable risk factors like obesity, exercising. As Dr. Pollak said, we know that exercise reduces risk of breast cancer as well.
Let's follow that up with early diagnosis, early intervention. Clearly, as Dr. Kesmodel said earlier, you'd like to identify any disease as early as possible with the expectation that you can intervene and alter the outcome. The question I'd like, and that is, what would you do in terms of trying to intervene early with these? Do you always need to have surgical intervention with early disease that you've diagnosed, or is there a wait-and-see attitude? Does that make any sense to someone says this is a tiny lesion? So what should they do? Is everything surgical, or is there a wait-and-see opportunity or option?
I think currently...
I realize I'm asking a surgeon, but...
I think everything's surgical, but currently I think we're still primarily doing surgery on patients, but it really, again, goes back to who you should screen, how often you should screen, when should you stop screening. A small breast cancer in an 80-year-old woman may never cause her any problems in her life. She may have other health problems that are more significant than a breast cancer, and in some of those patients, we can use one of those estrogen blockers, the aromatase inhibitors, and the patient can go on that treatment, and we may never have to do surgery for that. And we actually sometimes utilize that approach for patients who we think their other medical problems are more significant than their breast cancer. If you're a healthy 75-year-old and you exercise and you eat well, then it might be reasonable to screen and consider doing a more standard approach such as surgery. And then, of course, there's these new developments that are coming through about using non-surgical methods such as radiation to treat breast cancer. And I think in the future we may be doing less surgery for primary breast cancer and maybe doing a little more for actually prevention than actually treatment. So I think we're going to be seeing that shift in the future.
So biopsy diagnosis of cancer is not automatically a surgical procedure. It's age is a component, and the medical condition of the person is also a component in your decision.
Yes, age and health.
Okay. Dr. Cullen, you covered a fair amount of cancer as a whole. Let me just ask you, there's a variety of risk factors that are multiplicity of risk factors that could potentially influence someone's chance of developing cancer. Beyond the two that you mentioned here, what are some general guidelines that you would recommend that would potentially reduce someone's risk of developing cancers? Is there such a thing?
Sure. We know that some screening methodologies are very, very important, and specifically the best example is colorectal cancer, which is one of the major causes of cancer morbidity and mortality. Colonoscopy is not only the best screening tool for colon cancer, and the recommendation currently is that you have a colonoscopy every 10 years from the age of 50 onwards. But colonoscopy actually is the only screening methodology which also prevents cancers, because most colon cancers start as a polyp, which is benign, and if it's left for a long time will go on to transform into cancer. Colonoscopies remove those polyps, and so they actually reduce cancers as well. So that's one example. And as I mentioned, we're understanding more and more that many cancers are preventable because they're related to viruses which are passed from one person to another. And we have vaccines now for a number of those. A great example, which is an area of research for myself, is papillomavirus, which causes cervical cancer in women, but it also now causes an epidemic of oral cancers in men. And those are entirely preventable. It's to me, tragic when I see somebody who comes in with one of these cancers, because now we have the technology to prevent those cancers from happening in the first place. But what needs to happen is there has to be widespread acceptance that children before the age of about 15 need to be vaccinated, boys and girls, against these viruses to prevent them from developing these cancers well on in their adult years.
My last question to you, Dr. Cullen, that is shifting gears a little bit. There's a very strong emphasis in the whole area of genetics and genomics, and the role it might play in both one's susceptibility for cancer and or the manifestations of the cancer itself. So my question to you is, how would you use this knowledge to impact treatment, or maybe diagnosis,
Sure.
treatment,
Sure.
and long-term prognosis?
So I think there are a couple of answers to that. One, and Susan touched on this a bit, for people with very, very strong family history, especially people of certain ethnic backgrounds, Ashkenazi Jews, have some breast cancers which are caused by mutations in specific genes, BRCA1 and BRCA2. And to amplify what Susan said earlier, if there's a strong family history, one of the things that we will frequently recommend is that you meet with a genetic counselor to say, based on that history, should we consider genetic testing, very specific genetic testing of an individual woman or members of a family. So that's an important part where, based on the family history, you may find people who should undergo more extensive genetic testing. With cancers that have been diagnosed, we are developing increasingly effective targeted therapies where, if there is a specific gene mutation, we know that a protein in the cancer has been altered, which now is driving that cancer, and we may have a specific drug to target that. So an example is, there is a relatively rare mutation in a certain type of lung cancer, not very common, but when it's present, a specific oral drug works very, very well. And so now we are routinely testing patients who are diagnosed with lung cancer to see if they're in the minority that will benefit from a very, very specific treatment. And I think over time we'll see much more of that. The genetic testing will point a patient to a very specific drug which will work in their specific cancer.
And in other words, this would be an example of personalized medicine you're describing.
Absolutely.
Well, I'm going to turn this over to the audience now. It's your time. It's real fun now. So if you wish, just stand up where you are and ask a question, and I will just try to ferret them. Yes, question in the back, please. Well, that's a very, very interesting question. Let's put it this way. we have been warmly welcomed in our 2 successive visits that we've had last year and this year. And as a consequence, this has certainly been very much in our thoughts. I cannot tell you that we're gonna be planting a flag here next week or next month, but I certainly believe that this type of response that we're getting from the audience here this year and the previous year certainly led us become much more interested in some relationship that can be more meaningful. We hope that at least these health matters will be a start of something larger. We have, as an opener, just as an opener, we have several of our hospital and School of Medicine leadership here, and their pockets are filled with their cards. And so we want to make sure that if there is ever a thought, a concern for a loved one and so, that we're a phone call away. But you're absolutely right. We're not there yet. But at the present time, we have great access. We have a concierge program that if patients wish to be coordinated care, a concierge staff can actually coordinate your care for you, coordinate the appointments for you, and allow that to become very seamless and smooth. So it can be done and has been done. Steve.
I probably asked about 50 questions, but I'll keep it to one. Dr. Cullen, we talk about a lot of cancers. There's colon cancer, and I don't need to tell you what they are. You know them far better than I. Are they essentially all the same in just a different location in the body, or is there a significant difference between a cancer called colon cancer and a cancer called, breast cancer?
It's a great question, and they're completely different diseases. There are more than 200 known cancers, and we treat almost all of them at the Greenebaum Cancer Center. So the biology and the reasons that you may get a lung cancer are entirely different from why you may develop or have a risk of developing prostate cancer, and we need to understand that. And similarly, screening and treatment are not the same. A lot of people ask me, will we ever see a cure for cancer? And my answer is that day is here. When I was a kid, my grandmother had breast cancer when I was a very little kid. Back at that time, if you were diagnosed with cancer in the United States, you had a 1 out of 3 chance of surviving the disease. Today, 2 out of 3 patients, about 65% of patients who are diagnosed with cancer in the United States survive. There are more than 15 million survivors in the United States. So, but the direct answer to your question is many, many different diseases. The more we know, genetics has told us that the diseases have some similarities but more differences, and the treatments that have evolved that have been highly successful are really tailored to the individual characteristics of an individual cancer.
Other question over here, sir.
There are certain, particularly post-traumatic conditions involving the knee primarily, that with better stem cell research could be associated with a lower risk of arthritis long term. So when you have an injury to the joint right now and you lose a piece of the cartilage, and this isn't necessarily big injuries, this can occur as a result of twisting injuries in sports, football-type injuries, even without impact, basketball-type injuries. There's no real good way to replace that cartilage right now. We have some variable techniques that are out there that work a percentage of the time. We know in the lab that we can grow stem cells to replace the cartilage that normally lives within a knee. But getting that from the lab to an actual situation where it reliably takes, if you will, where it reliably grows within the knee, in a way that restores the normal mechanics of the knee and reduces the risk of arthritis long-term, that link we're not there with yet. I think if we're going to long-term reduce the risk, we've got to advance those technologies further, and that's a tissue engineering approach to taking the stem cells to a format in which they can be implanted reliably to make them work.
Another question? Yes, sir. Dr. Rubenstein. A microphone, please. We have an alumnus
Thank
here.
Howard Rubenstein. I graduated Maryland Medical School 55 years ago. I think from what came out, today that I think was very important, I think was early diagnosis, seeing competent medical personnel for the problem that you have. And there are too many people that I know socially that don't have a doctor. They live up north 6 months out of the year. They don't have a physician here. But I also want to emphasize what has been said in terms of being active physically, active mentally. It makes a difference. Although my voice isn't strong, I'm 80 years old. I tore 2 shoulders, tore them again, lost an elbow, had my first kidney removed for cancer 20 years ago, the second one removed 7 years later, 3 years of dialysis, transplant, on chemo 5.5 years, and active, fully active. That's, to get up here, I'm touting myself, but I'm just saying there is life with problems, and you have very good people up here that are not directing you to them personally, but to getting medical care at the right time, which is early.
Thanks very much. Thank you very much. Yes, quick question, comment right there.
Yeah, Dr. Reece, isn't the key to this funding from NIH and other sources that we get any medical research done?
Well, yes, it is. I mean, just let me elaborate on it a little bit. The NIH is the largest funder of medical research in this country. And as of this year, the new budget is going to be at basically a $29.8 billion budget. And clearly, what is happening across the world is that the percent of increase that Russia, China, Europe, Brazil has made in their equivalent of NIH is in the double digits. Ours is actually a decrease. So there's no question that it's a good-sized budget. I don't want to minimize the budget for research across the country. It's just that the rate of growth of inflation and the rate of growth of cost is much less than the rate of growth of research funding. So it does limit our ability to do things. But having said that, we are pretty fierce at the fact that we need to continue to improve care. And the only way we're going to do this is through research. So we have used the resources that we received. We have been very competitive and tried to secure our share and more to be able to advance research, recognizing that there is a reduced rate of growth of the budget in the federal government. Other comments, questions? Yes, in the back over there.
This could be a politically not correct question, but I'm wondering if you could fast forward 5 to 10 years, how you see the Affordable Care Act impacting your research and the great work that you're doing.
Let me try to answer that one. I want to answer it in different ways. Most academic medical centers across the United States, because of where they're located and what they do, they actually do about 10 to 20% of unreimbursed care. In fact, the University of Florida, my friend is the executive vice president, they do 21% of unreimbursed care. So about 21% of the people have either no care, no insurance, and thus the care has to be given for free, but somebody pays at some point. So for academic medical centers, it's better to get low care, low pay, than no pay. So it will be an improvement somewhat. It's not going to be great, but it's going to be an improvement than zero. That's the clinical side. We're not, because of the rollout has been such a terrible situation, it'll take some time to sort of work itself out. But we think that we're expecting it to have modest impact. Here's another thing that's very important. Preventive care in America is not reimbursed. And in fact, I was testifying in Maryland legislature a couple of years ago, and one of the legislators asked, why aren't you doctors, basically doing preventive care because we know that if you prevent something, it's better than having to try to treat it. I said, well, one of the reasons, I'm not going to defend all doctors across the country or the state, is that preventive care is not a reimbursable item, so people don't provide it. In the Affordable Care Act, preventive care is reimbursable. So it's my expectation that people, if they're being paid to provide preventive care, will obviously take advantage of it. That's my expectation. A third, and lots of women are here, there is a segment called preventive services for women. For example, talking about cancer, pap smears will be no copay at all. Breast care with no copay. So there are several preventive care for women that has been shown to reduce risk, reduce outcome, in which they'll be cared for without copay. Now, there's some downsides to it. I don't want to minimize the downsides. I'm not going to be Pollyannic. There are downsides to it. It has its flaws. But from an academic standpoint, we anticipate that there will be some added reimbursement to people who never had insurance to begin with and we'd have to care for. Anyway, they come to us, we have to care for them. So we'll be a little bit better off. And those preventive services that we being medicine in general, have never gotten reimbursed for, will now be reimbursed. And most importantly, I really believe that because it is now a reimbursable item, it is my strong expectation that people will avail themselves more of it, and doctors will actually try to provide that counseling because they'll be paid for that counseling, when in fact, they would not have been paid otherwise. Is there anyone who wants to make a comment? Andy?
Yeah, I agree. I think that's going to be true for the very limited number of diagnoses that are specifically favored in that direction like that. But for the majority of people, we talked about joint replacement before and how important it is for people to have access to joint replacement when they need it, good, high-quality care when they need it. And unfortunately, they're not going to be able to afford it anymore because the copays are going to be too high. The deductibles are going to be in the $3,000 and $4,000 range. So you're going to have to figure out how to be able to afford that deductible in order to pay for it. So it'll be unaffordable for those people, for many people, unfortunately. We're going to have to figure out how to manage through that. The way it currently exists, I don't think anybody believes it can continue to exist 4 and 5 years down the road, as you just described. That has to get fixed. People are going to be up in arms when they realize they can't afford things that they're currently able to afford. There are big pieces of it that are highly problematic that still need to be addressed.
Another comment I saw. Louise, did you put your hand up?
But that's not the only source for funding. And I'm not trying to leap into softball to you so you can talk about fundraising. But I do think it's important that people realize that it's just not the federal government and the state and the occasional big bequests that make a difference in funding. So if you all could comment on what you see, what role that's going to play.
I think that was a very, very nice softball. And I appreciate it very much. And it's absolutely true. It is not enough for us to depend exclusively on the federal government to provide the funding, because it never will be enough. And what has actually been a very good adjunct, an additive, is really philanthropy. And I start by mentioning the Greenebaum's gifts most recently. And those endowments continue, and they provide sources of funding for the cancer program, for example, source of funding for the Parkinson program. Many of these programs described here have received various types of philanthropic support to keep them going. So that's a wonderful comment. Anyone wants to make a comment?
Yeah, to echo that, I think, the Greenebaum Cancer Center, since I've been there, we have attracted $333 million in federal research funding over and above the level we were at before the Greenebaums made their gift. Now, the Greenebaums did not contribute $333 million. Their gift was extraordinarily generous, but it catalyzed the transformation of what it is today. And the contributions that I talked a little bit about and the increase in federal funding that's come about as would not have happened were it not for that philanthropic gift more than 10 years ago that really pushed the Cancer Center to the next level.
Dr. Pollak and then Dr. Schulman.
The philanthropic gifts in our department create endowments that create a source of revenue for our investigators on an ongoing basis that serve as a huge tool for me as a department chair to attract the best and the brightest surgeons from around the country and around the world to the University of Maryland. It's great to have a wonderful clinical environment, but a wonderful clinical environment with the nurturing investigative environment, the nurturing research environment that comes with those endowed funds is a wonderful way for us to bring the best and the brightest and to ensure the future of the institution.
Dr. Schulman.
You never know where an investment of a donation is going to go in the future. And about 15 years ago or so, a patient donated a sum of money that permitted me, when I arrived at the University of Maryland, to begin what we call a patient registry or database, such that from the time I started there, which was 14 years ago, we began to collect in-depth information on every patient that we saw, so that now we have 11 years of data on patients we've been seeing. Over 1,500 patients are in the database, over 20,000 office visits with all sorts of information.
These are Parkinson's
about,
patients?
well, Parkinson's and other movement disorders. And as a result, there were more than 1,500 Parkinson's alone. So as a result, it bears incredible fruit that you could never actually envision at the start of the thing, because we are now starting to do genetic sampling of all the patients we can connect with that we have this rich data, such that we can begin to dig down into why is it that some of the patients progress slower and others more rapidly? Why is it that some develop more problems with walking and others more with memory? So we're going to go back now and do genetic analyses that never would have been possible when we began to collect the data. And this opportunity is in fact launching the career of a new junior clinician scientist. So it's an incredible investment to see how something can grow over time.
Steve?
You all share your progress and success with other hospitals in the United States. And is there a collaborative effort when you come up with something that moves the prevention or treatment of illnesses and diseases along?
I'm going to answer start. If it's great, we patent it first. Then we publish it, and then we share it. No, I was being a little facetious, but we do patent it early. Anyone who wants to take that?
That's perfect. I mean, yeah. But more so than in any other business, when we find out things that are new, we share it with the rest of the world. We brag about it. And the idea that we patent it first, we try our best to patent it first, but that those of us up here understand that not every investigator in the institution does. They think it's wonderful, and they get it out there and get it published, thinking that that the real return is going to be the next grant that you get for more research in that area.
Oh, yes.
Mr. Atman.
Lenny Atman.
One of the biggest things that everybody around here should know, and the rest of the world.
The microphone, please.
What everyone here needs to know, not only does the University of Maryland share, they share very well. Their shock trauma unit is well known all throughout this country and all around the world. And we have shared that with everyone. I've been privy to it in various parts of the world. So we do share, and we share it very well.
Thank you. Thanks, Mr. Atman. Now we're just about two more minutes? Two more questions? Two more questions. Yes, sir. Over there. I'm sorry, was there a question over here while we were with the microphone? Since you're right there with the microphone, why don't you do that? I don't want you to run around the corner. Was there a question right here? No. So then we'll just take this gentleman here. I'm sorry to give you that much extra exercise. Can you?
feel like I'm hogging the phone, but the mic. You talked about the family history and being proactive. What if family members have a history of a certain type of either Parkinson's or cancer? What should one do?
Do you want to take that?
I'll let Dr. Shulman speak about the neurologic issues, but there are, in most large cancer centers, good genetic counselors that are available. We have a genetic counseling service, and anytime there's a question of a family history that we can't explain, we'll usually refer the patient to the genetic counselor to really spend some time, go through the family history in enormous detail, and those people are trained. You know, this history suggests one of 3 possible explanations, and should further testing be done. Our genetic counselors actually work across our system hospitals so that the services that they originally provided at the Greenebaum Cancer Center are now available at all of the system hospitals. And much of that's done through video conferencing, because these questions, especially in the smaller hospitals, are somewhat rare. And we found that it's very practical to have a high-quality video link up where the genetic counselor in Baltimore can be talking to somebody on the Eastern Shore and going through things in a lot of detail, and then say, you know, it is worth it for you to come into Baltimore and have some blood testing and follow-up testing done.
Is there another question?
I was going to add you know, in the neurologic field, there's really, over the last 10 years, there's been an explosion of information about genetics in neurologic disease. Nearly 20 genetic mutations have been found for Parkinson's disease right now. But that information, as it is rolled out that this is an identified gene, does not automatically mean that we know how to apply that information in terms of clinical practice. And so we are kind of right in that pivotal point right now, waiting for enough information that it would make sense to be able to tell you carry that gene. It doesn't make a lot of sense. Number one, the test is incredibly costly, and that's another issue. We have to get to a point where the panel would be a reasonable price, and that's coming because the price is coming down very quickly. But secondly, that when you find out that you have this gene, like Dr. Cullen said, that you actually have something to follow up on in terms of practice. It doesn't do you a lot of good to know, you know, I seem to have a 5% increase of a risk.
Well, yes, please.
I have a quick question. I'm maybe the only pharmacist here, and I know medicine runs our salaries, but what about preventative medicine for nutrition, diet, and maybe environmental toxins?
What was the first part of the question?
Preventative care with nutritional counseling.
Anyone wants to handle that?
Sure. We have a wonderful group of nutritionists who work in the cancer center. And so when patients are diagnosed, they'll meet with the nutritional team and get counseling about that. Unfortunately, frequently the horse is out of the barn by that point. And that's why my message is to the biology teachers at the high school level. The most critical part of nutrition, as we know it, is to keep your body weight at an appropriate level from childhood on forward. The data so far on nutritional supplements to prevent cancer has been pretty disappointing, frankly. A lot of clinical trials have been done with vitamin E, vitamin A, other things, and they have been either negative or actually harmful in ways that we don't quite understand. So nutritional supplementation to prevent cancer has been an area of active research, but has been fairly disappointing to date. In terms of environmental toxins, the single biggest environmental toxin is tobacco smoke. The second is radon. But the number of cancers that we know of that are caused by environmental causes other than tobacco and radon is small. It's probably in the single digits. It's probably 3 to 5%.
Do you know if anyone's looked at soy protein that's being put in everything?
I can't answer that for you. I don't know of longitudinal studies about that, but I'm sure that others have looked at that, and it's something we could find out for you.
Okay, thank you.
Let me just, in the interest of time, we've been here together, having some fun, I hope. And let me just say, first of all, I thank everyone for being so cooperative and participatory in this effort. I want to thank our panelists for their engagement, for their comments that they shared, and their willingness to answer. And I want to just close my part of the session by simply saying that for those of you who wish to engage these physicians or any other for matters of interest to you or your family, first of all, you can call us. And I would ask you to, any one of us, I'm going to just ask those members from Maryland to make them yourselves available so that folks who wish to engage with our institution can feel free to do so. We're very, very happy to be helpful. So thank you very much. Let me transition now to...
Well, this has certainly been a very engaged, active audience, a very educated audience. Very, very pleased to see that. And we thank you again for your attendance and your participation today. I do have to add a comment that you're seeing 5 of our most talented physicians at the University of Maryland Medical Center and School of Medicine. We have nearly 1,000 full-time clinicians. Most are subspecialists in just about every imaginable area you can think of. So know that you are now a friend of the institution. Many of you in this room have always been a friend of the institution. Know you deserve access to the best in a timely way, and we can make sure you get that access should you or a family member, as Dr. Reece mentioned, have any particular need at all. We're always happy to be here and available to facilitate appointments or consultations for you. Many times, our physicians will also advise you on physicians to see in other parts of the country. If you are in other parts of the country, they're happy to make those recommendations. They're well networked nationally, and again, happy to help you with any referrals or advice that you may need. We're just going to ask you, if you would, to take 1 minute and give us some feedback. Our staff is handing out a quick evaluation form here. We got good feedback last year and then made changes to our program, I think improved it for this year. If you give us more feedback about today, we'll use that for next year, and hopefully we'll be back again. We'll pick topics that are of interest to you and your friends and neighbors. So if you can take a minute and fill that out, it would be much appreciated. Our physicians will be around for a few minutes afterwards if you have individual questions that you'd like to ask them. They certainly will be available and very anxious to help you in any way we can. So I thank you again for your time. Thanks from the University of Maryland Medical Center and the School of Medicine. A special thanks to Dr. E. Albert Reece. He does a great job facilitating here, doesn't he? I think there's another career here, Al. You enjoy this. And again, thank you for your time today. Have a good evening. Are we still on? Okay. I was just mentioned also that if you stay in this room, please enjoy each other's company. There is a reception that will occur in this room. And again, our physicians are available for your questions. Thank you. Okay. So we want to do a group picture here.
Dr. Cullen, want to take a picture? Dr. Pollak. Quick.